Hello everyone, good afternoon. As mentioned, my name is Toluwalope Efunkoya and I'm a current PGY2 pharmacy resident here at Cook Children's. I did my PGY1 residency here, so I'm a loyal Cook Children's resident and pharmacist. This evaluation came about just me wanting to combine my interest in medication safety and clinical decision support, so that's the IT side of things. And so every year we have to do an MUE, and so that's where this project kind of came about. I have no conflicts to disclose to you all, and after this brief presentation, I want you all to be able to understand the impact of implementing an advisory alert on outpatient prescribing rates for naloxone to enhance patient safety. So just a little bit of background. As we all know, naloxone is a life-saving medication. It's used to reverse the effects of opioid overdose, which can help to mitigate the risk of fatal outcomes that we can see with overdoses or ingestions in pediatric patients. So naloxone is often underprescribed alongside opioid medications, leaving patients at risk for opioid-related harm. So the evaluation aims to determine whether the implementation of our BPA, which is a best practice alert, has effectively increased naloxone prescribing rates at our institution here. Just to give you all a little bit of background on the timeline of this, so the BPA, prior to the BPA being implemented, there was no institutional standard in naloxone prescribing. So there was no recommendation that if you prescribe X amount of opioids, you must prescribe a naloxone along with that. The medication safety team and the opioid stewardship team kind of collided, and they said, well, we should probably have this sort of standard where we have at least a recommendation or a prompt for providers to send out these naloxone prescriptions when they're prescribing opioids. And so the initial BPA was meant to fire for patients who are receiving greater than 14 doses of opioid prescription outpatient. And so with that initial BPA firing started in January of 2023, it was initially fired for all prescriptions rather than just the greater than 14 doses initially. So it was stopped, paused, and then reinitiated in April of 2023. The Opioid Stewardship Committee and the Medication Safety Committee then kind of reconvened and said, you know, well, an infant versus an adolescent, 14 doses could mean two different things. And so an infant getting, you know, maybe greater than 3 or 4 doses is still toxic versus an adolescent who may need 14 doses to overdose or something like that. And so they decided to optimize the BPA and said, we want this alert to fire for all opioid prescriptions being sent outpatient. So the provider still has the option to send it or not, regardless of the amount of doses they wish to prescribe. This is the BPA pop-up that was implemented by our clinical decision support team. So once they put through a prescription for an opioid, then this pop-up comes and says, hey, here's the order for naloxone, you're prescribing an opioid, would you like to co-prescribe this? And it's already a pre-filled out prescription, so there's not much work besides saying accept, and it's automatically on the patient's MAR, and it's been sent to the retail pharmacy. The goals of the MUE was to evaluate the opioid and naloxone prescribing rates, analyze trends to provide a response to the BPA, and then determine the efficacy of the naloxone BPA implementation. This was a retrospective chart review to identify patients prescribed outpatient opioid prescriptions prior to the BPA, so we did a 1-year look back from prior to January 2023, and then after the relaunch in April of 2023, and then the months prior to the optimization in June of 2024. The inclusion criteria, obviously all patients who received outpatient opioid prescriptions at Cook Children's Healthcare System were included in this study. We looked at the number of outpatient opioid prescriptions pre-BPA, during, and post-optimization, and then we also looked at the number of outpatient naloxone prescriptions pre-BPA, during, and post-BPA optimization. Going right into some results. These were like the big heavy hitters, or I would say the big takeaways from the results. So the BPA implementation increased the naloxone prescriptions by 3,366%. That is a comma and not a period. So yes, that much of an increase. And I'll show you some graphs in a little minute so you can see the visual differences in prescribing. There was a significant increase in monthly prescribing rates of naloxone. So for the pre-BPA to the initial BPA, the p-value was 0.001, and the initial BPA to optimization BPA, that p-value was less than 0.001. So both statistically significant. And lastly, the BPA optimization led to further increase in naloxone prescriptions at 738%. Taking a look at our monthly averages, on the that is your left-hand side, you can see the opioid prescriptions have an average of around 400 to 500 prescriptions per month at the different phases. The blue is the pre, purple is the initial BPA with greater than 14 doses, and then the orange is the optimized timeline. I just want to point out that the optimized timeline is only from June of 2024 to about September of 2024, because that is when I started collecting my data. And so you can see naloxone prescribing rates there. For every one prescription prescribed for opioids, you can see about 0.002 in the pre-BPA time period of naloxone prescriptions. And for every one of opioid prescription prescribed during the initial BPA, we can see 0.051 naloxone prescriptions prescribed. And then with the optimization, you can see that greater jump with 0.436 for every one every one opioid prescription prescribed. So from this, we concluded that the implementation of the naloxone BPA was successful in increasing prescribing of naloxone alongside outpatient opioid prescriptions. And some of the discussion we had was that this BPA helped to highlight the gap in naloxone prescribing. And so having naloxone on hand, whether patients or family members choose to pick that up, is up to their discretion, but at least prescribing and educating families on what naloxone is. And you'd be surprised how many people don't know what it is or why you're prescribing it for their child, though they are getting an opioid sent home. The optimization further spiked that, so you can see that providers were seeing the pop-up and saying, oh, okay, I'm prescribing an opioid, let me go ahead and send this naloxone prescription. It's already filled out, it's an easy push of a button. And despite the increase in naloxone prescriptions, it's still not a one-to-one, so there is room for improvement. But as I said before, the optimization data was only from June of 2024 to September of 2024. So there is some more data out there right now that we could probably look at, and maybe it's a little bit closer to one-to-one, hopefully after with some more months that have gone by. But yeah, so naloxone is good, we should prescribe it, and we're doing great. Thank y'all.